Okay. Well, hello everyone. I'm Mary Patterson. I am the Vice President of Clinical Operations at BrainCheck, and I'm excited to welcome everyone to today's webinar, the first in our new webinar series. So today's webinar is going to be focusing, it's revolutionizing cognitive care through remote at-home assessments. And with us today is Reza Ghomi. He's BrainCheck's Chief Medical Officer and neuropsychiatrist, focusing on neurodegenerative disorders at Frontier Psychiatry. So Reza, I'll pass it off to you to introduce yourself.
Yeah, sure. Thank you. Hi, everyone. I'm Reza. I'm been with BrainCheck. I've lost track of time now, quite a few years. Not long after it was founded, I got involved. I think just a relevant background is I am a neuropsychiatrist, specialty trained, both neurology and psychiatry, and including movement disorders and behavioral neurology. Really, the idea was right focusing on neurodegenerative disorders. And pretty early in my career, realized that there was quite a bottleneck when it came to cognitive testing and getting people through the whole, workflow to get them to the point of diagnosis and care planning and the juicy stuff that we know has good outcomes for patients, but patients were really blocked. And so, uh, all of my work really centers around how do we take these 7+ million Americans who live with cognitive impairment but don't have a diagnosis and just help them move down that path. And as you know now, since I started, I was really focused on a lot of the things we do know, like the 40% of modifiable risk factors. Now, as you've seen the last few years, we've made some splashes with new drugs available. Well, it turns out those drugs really are only available to people that have cognitive testing again and well-characterized illness. So we're kind of back to where more and more reason to do this work. So I'm happy to speak with you all today, of course. This is very close to what I really spend my time doing. Should we
Fantastic.
jump in? Yeah.
Thank you, Reza. All right. So first off, just want to review a few items to optimize everyone's participation in today's webinar. The session is going to be recorded and attendee microphones are going to be muted for the duration of the event. However, we do encourage everyone to submit questions just by quickly clicking on the Q&A button on the toolbar. And you can send questions at any time throughout the discussion, but all questions are going to be answered at the end of the session as time allows. And if we don't get to it, we'll be following up separately after the event. Okay. So as Reza already touched on, cognitive impairment is extremely common and predicted to become more prevalent in years to come. And as many of us know here, it's underdiagnosed. And then when diagnosis is achieved, it's often too late for disease modifying therapies that are now available to be of benefit. Traditional pen and paper tests are challenging to implement, oftentimes only further complicating early detection and the post diagnosis navigation for providers, patients, and their caregivers. And with prevalence on the rise, new approaches are really becoming essential to increase access, accelerate intervention, and then ultimately improve patient care. So, what BrainCheck's products offer is a comprehensive digital solution from screening and monitoring all the way to care planning. Starting on the left-hand side, with BrainCheck Screen, providers are able to efficiently identify the need for further cognitive testing if that's warranted in as little as 3 minutes. And this can be done fully remotely at home or even in a provider waiting room. Screen's main purpose is really to expand access to those quick cognitive health checks and catch impairment early. And then, if needed, establish the medical necessity for further cognitive testing. And then, so if the screen result recommends further testing, the patient is then going to move on to complete the extended cognitive battery, which is available through BrainCheck Assess. This is our FDA Class 2 medical device. Um, it takes about 15 minutes to complete and has a proven sensitivity of 88% and a specificity of 94% when differentiating normal cognition or healthy cognition from either MCI or dementia. It covers 5 key cognitive domains, so immediate and delayed memory, attention, executive functioning, and processing speed. And I think one of the biggest benefits of the tool is it enables providers rather to accurately track cognition over time and ideally improve both operational workflow and profitability, given that the assessment is fully reimbursable. And then finally, with BrainCheck Plan, this is an offering of a comprehensive care plan for patients that have the identified cognitive decline and then their caregivers as well. The care plan integrates both CMS and guide requirements, and helps really to streamline documentation, personalizing recommendations, and again is fully reimbursable. So with that overview of BrainCheck's products offerings, we're going to dive into the real purpose of today's event, which is how remote at-home assessments are advancing the cognitive health space.
Great. Thank you, Mary. And so what's been gratifying, I'll mention going into this has been, we are seeing more and more support from the payers because, obviously they hold a lot of power in our day-to-day workflows. And so the guide model is a really good example where we had developed a care plan years ago, actually. And the guide model essentially is how do you implement and, carry out a care plan? That's really what it comes down to. And so, on this slide, you'll see we're talking about what were the challenges and what's the solution that we're really trying to put forth today. In terms of challenges, right? The reality is, although we have these tools, we still need our providers, our primary care doctors, and really all providers being vigilant. And so we have limited time, right? Even in my own practice, I need to be reviewing hundreds of screenings. Well, the reality is no one has enough time to really look at their whole patient panel without some version of automation or some sort of workflow, right? Optimization. Something has to happen. And so if we rely just on our EHR, again, we run into trouble. In previous work, I've always been involved in quality improvement work at many levels in the hospitals I've been a part of, and things from varying rates of colonoscopy to breast cancer screening. So this is no different. And where we found variations are the same types of places we find variations with cognitive screening, right? If the EHR doesn't allow for certain workflows to be implemented, you see pretty dramatic differences in terms of the population being reached with screening tools. And so what we found that's more specific with cognitive testing is some providers have varying degrees of comfort, right? It's difficult, right? Because you're starting a journey that has some really serious consequences. You're thinking about, am I going to diagnose this person with dementia? What if I'm wrong? I've come across this a long time, many times over my career. And where I really try to reassure people is the chances of a false positive when you go down the dementia pathway and ultimately diagnose someone are very, very low, right? In general, your gut, if you're already leaning positive, is almost always accurate. Now, in terms of getting the exact diagnosis right and the stage, that's important. But though it's just a very unlikely situation. And I also remind people the risk of a false positive is very low because what's the worst that's going to happen for a patient? Historically, it's they're going to get a whole bunch of good attention, different types of therapies, address their hearing loss, diet and nutrition and exercise. I mean, there's not a lot of risk there. But all of those things sort of added up and cause, and many other reasons, cause populations, to have varying degrees of screening completed. Screening's also just not paid for. Payers don't really pay for screening. I mean, very little in some cases, but it's not enough to move the needle, given how much administrative overhead it takes to actually implement these things. And so those are just some of the challenges. I'm sure many of you can think of more, and please feel free to chime in. Every practice is a little different, of course. At this point, having worked with probably a couple hundred practices at least now, just in myself personally, I've got a sense of what's standing in the way. In terms of the solution, what happened was over the last couple of years, faced with this very issue in my own clinic, even despite being someone who's, always screaming from the rooftops about cognitive testing and cognitive screening, I had a lot of trouble with my own practice. And I have about 30 to 40 providers myself in a clinic, and we had very divergent opinions. We had varying ranges of screening. And so realized the same thing we realized years ago when we raised our colonoscopy screening levels across, several hundred providers to over 95%. Same idea, we needed to automate. And so we came up with a solution with a third party partner here with MedFlow. And the idea is, how do we get rid of these bottlenecks? How do I take away the stress or even the time needed for a provider to even make a decision, to not even have to? Because at the screening level, we really don't need to. We have enough information, right, from at a population level to know should I screen? Are you over 65? Are you here for Medicare annual wellness visit? There's all kinds of criteria you can use. So let's just get people screened without asking too many questions and then go from there. So that was the idea here. We rolled out an automation. We started screening the entire population without any orders or without any decisions needed. Um, and I think that's kind of wraps up this slide. And what was nice is with this automation, because it's relying on standardized data, FHIR or HL7, if you're familiar with these terms, these are interoperability terms where EHRs are all using the same sort of format for that data. So we relied on using the data available in those formats so that it was applicable across any EHR. Can go
Okay.
to that next slide, please. Thank you. And so here's some initial results with our own implementation. What we saw here, and if you kind of, I always try to show as much in terms of visualization as possible. What we found was, and this was just in the first couple of weeks, so we kind of dove in. We knew we were going to have some learning to do and some bugs to work out. And what we did was we found that we had 122 screens completed just in the first couple of weeks. So just to put it in perspective, again, across a practice where we were seeing approximately 4,000 patients per month, not all older, so a range. We see all ages, but in terms of people, eligible for screening, prior to this implementation, we were very, very low. I mean, a tiny fraction of this. So just right off the bat, just based on some initial criteria, based on age alone, we just had 122 completed. And what was nice there is then I can all of a sudden start to triage. So part of my population screened okay. And so I can really focus on those you can see it's about half, it's about 56% were identified at risk based on BrainCheck screen. And so I can then grab that 56% and move to the next stage, which is give them a full BrainCheck assess, which is it's not a screening, it's a test. It takes a little longer. It's not all that much more impactful on the patient side of it. It takes a few more minutes. It's proctored in our case, and that can be done remotely or in person. But that all of a sudden then kind of moves the patient down that pathway, removes delays. Certainly don't have to wait for formal neuropsychological testing, which in my community is approximately on average 1 year wait, which it's really it's too long when it comes to this kind of thing. So you can see test volumes increase. What was nice is once we get to the BrainCheck Assess, that is a fully reimbursable piece. And so we saw volumes, of course, go up, but reimbursement went up, which at the end of the day, I need to be able to pay my social workers, my medical assistants, my care assistants. That these are all positions which are not reimbursable in most cases. So what's really nice about the BrainCheck Assess being reimbursable is it can cover our overhead. That's one of the biggest reasons I think nationally we see so little use of cognitive testing within primary care clinics or specialty clinics is simply there's not very easy ways to cover our overhead like there are with other billing codes. And so that third little visualization on the right there, the bottom right, shows how, based on per test, pricing, and then per seat, depending on the kind of which model you kind of use in terms of how you're paying for the testing. You can see revenue expansion. And again, we want to talk about the reality. I'm a physician first, but I can't ignore the fact that medicine in the U.S. is a business. Doesn't matter if you work for a nonprofit. It doesn't matter if you work for any kind of organization. You have to be able to cover your costs. It will catch up to you eventually. And so the reality is we have to think of ways, how do I ultimately do what's evidence-based, what's best for the patient that I believe in, but at the same time, pay my bills and have the staff I need to. This also allows us to have that extra layer of support for patients. So, for example, my care navigators that proctor the test, and then going on, we have a team of social workers that are just invaluable, that spend time with the patient to then go on and do the plan afterwards and implement various resources. That's That's a pretty big difference maker. I would argue that's the biggest difference maker for anyone with a diagnosis of cognitive impairment or dementia, is simply focusing on that 40% of risk factors that are modifiable. And we just, as we all know, for those of us who are physicians or the medical side providers, there's just not enough time, in our visits to cover that. I think that's everything I wanted to say on this slide. This was a slide, and big thank you to Luis from MedFlow for kind of helping me think through some of these steps. You can see that 122, that first yellow bar, that's where we just started. And this slide is really meant to show the potential. So we are continuing on the spectrum. We are gathering data, and I actually we've started writing a paper to capture, so to publish in a peer-reviewed journal, some of our initial work here. But just those first visit screens. So just based on that kind of small population, relatively small population, just puts in perspective, there's still quite a bit more of folks to capture. And a lot of these are areas to capture revenue, to capture reimbursement, but also just characterize your population even more. So there's folks coming in for the first time, screening them, but you can see as we go down from left to right on this bar graph, there's orders that are not completed, right? So as we all know, not everything gets complete the first time around. So going back and capturing those. There are providers that see patients that maybe didn't fit some screening criteria, and that's okay. They might decide in that moment, hey, I want to order the full assess right away. This person clearly has a concern. And remember, to cover for reimbursement in terms of what insurance requires is simply medical necessity, and that's defined by a patient, a provider, or a caregiver or a loved one's concern for cognitive impairment. So it's a relatively low bar, but if that concern is there, you might say, oh, why not just order the assess? So there's that group. There's at-risk follow-up. So folks that you want to continue following, maybe they were at the threshold or just below, but obviously you're going to continue screening. Age being the biggest risk factor for dementia, right? So every year we're getting older, our risk profile is changing. So just because I'm screening normal this year doesn't mean I'm going to next year. And then that bigger bar towards the right, the annual wellness visit, AWVs, that's what that means. So I think probably all of us or most of us on this call are familiar with Medicare annual wellness visits. There is a portion attributed to cognitive testing. Right now, the bar for that is very low. So out of necessity, most of us do mini cogs or something very simple, but we're trying to offer a solution that allows a more in-depth testing so that the screening portion is just a little bit more sensitive so we can capture more of that population. Because we all know mini cogs are relatively easy to pass. And so you can have a reasonable amount of impairment and still have a normal mini cog score. So there's quite a few there to capture. So this is showing the sort of potential subtotal based on a sample population of people that need cognitive screening. And as you can see, it's quite a big number, even in a relatively small population. It adds up pretty quickly. And feel free to, if anyone has any comments to Mary or anyone, just jump in. But that's
Yeah, before we move on to the Q&A portion, Reza, I'd love to hear, um, if there was any patient feedback received or that you've become aware of through standing up this new workflow about, completing cognitive testing in a remote setting, from the patient perspective.
sure.
And then also if there were any patient populations that were able to be included for cognitive testing or, were accessible through the remote administration specifically.
Absolutely. So I honestly have been pleasantly surprised at the uptake just based on initial outreach. So the screening we offer, and I'll make sure we get to everyone's questions. Some of these are touching on this very topic. We offer text message, and email notifications. And I was surprised that that percentage you saw, that was with no follow-up. So people were completing. We had about almost a third of patients just did the screening with just kind of being poked once digitally in an automated fashion. That surprised me. I thought it was going to be lower, to be honest. And so that I thought was really good news. It also showed me that patients care and want to have this information. So to the question of, do people kind of open their email, SMS? We're exactly working on that. So about a third did on the first try and have continued to. And then we're doing things like once we reach a certain point before the visit, if they haven't opened or completed, we are having some initial automated messaging. And then if it comes down to it, we have a care navigator who's full time on basically doing screening and testing with BrainCheck and on our staff. And so she will call or kind of pursue that. And really at the end of the day, if some portion of patients will show up to the visit not having done it, we're trying to minimize that. And then the provider can kind of have a reminder to kind of discuss that with them. But great question. We've all been there, we all get, I'm a patient myself, right? I get reminders and, we're all busy, so I ignore them often. And what was the second part of your question, Mary? You talked about
Any
people.
patient populations? I know that
Oh, that's right.
Frontier specifically covers a really wide
Yes.
geographical area, and if there were any populations that were accessible that otherwise wouldn't have been.
So great question. My business, that telehealth company that we've built, physician run and led, what Mary's referring to, is based in Montana. We see patients in Alaska, Idaho, Montana, and Wyoming currently. So very near and dear to my heart is reaching patients that otherwise don't have access, or otherwise have to drive 8 hours, or just not going to be able to. So.
Yeah.
Yes, we cover all parts of those states too, and we've seen good uptake. Now, sometimes can internet bandwidth be an issue? Not as much as you might think. It's actually our testing's set up and optimized so that you can complete it with pretty minimal, access. But sometimes that is a challenge. But we are seeing participation from folks who would never otherwise consider going to a doctor or going further for testing. A lot of our population, there are some that would say, hey, okay, sure, I'll drive to Salt Lake City or Seattle or Denver, or I'll, fly there. But the majority are saying, just do what you can for me here. I don't want to go further, or, I'm a farmer or rancher or whatever else that they're doing. I just don't have time. So we've definitely seen that. And that is something we're touching on in this write-up that we're doing now. Um,
Great.
any other thoughts before I jump into the questions?
No, thank you for answering those. I know it's obviously related to how
Yeah,
remote access really impacts the patient specifically.
absolutely.
Yeah, I'd love to move into the questions portion.
Sure. And I'll say on that topic too, it sounds like from research I'm seeing just nationally, patients really do appreciate having access to whatever intake type of work they have to do before an appointment, regardless
Yeah.
if it's a remote appointment or brick and mortar if they're coming in, to your office. Patients seem to like filling out their paperwork ahead of time, whether it's a depression questionnaire, whether it's your consent to treatment, your financial consent. And so this kind of, for us, fits into that. It's kind of like this package for new patients. Here's the things we need. And then depending on the patient, we add on different types of screening. Um, in terms of the question, and I'll bounce around a little bit based on the questions. How does MedFlow or BrainCheck work with the EMR? Do you work with eClinicalWorks? Great question. ECW is one of the largest. It's one of the Athena and ACW are the two largest outpatient, EHRs out there. So yes. I saw Hope, you said, it says, I see that thing popping up. Did you want to answer that, or do you want me to go ahead?
Oh, no, go ahead.
Oh, okay. I see. It's probably just, okay. I'm getting used to this format. So what's great about ECW is, yes, we can work with ECW. They use the same sort of interoperable type of format. So the same sort of like criteria we might grab and the same type of ordering mechanisms, all those things are uniform across those EHRs, which is helpful. There's the process, let's say you're on ECW and you say, I want to use this tool. It's sort of like a marketplace vendor. There's a couple steps to be taken to kind of activate it and turn it on. But it's not like, you're building something from scratch and waiting months and months and months. There's some steps to take, but it's absolutely doable. And in this case, what it looks like on our end is behind the scenes, as soon as in our EHR in Athena, in our case, a patient registers, and we have various sources of registration because we get about 80% of our referrals from primary care clinics directly. And then patients can come and also refer themselves. But regardless of how they come in, as soon as that profile is set up and their registration is started, MedFlow detects that. It's set up to detect that a patient fitting certain criteria, age, location, whatever it might be. And that's what's nice is you can set up. That's customizable. Once that's detected, it's taking that patient and it's automatically ordering and sending them a screen behind the scenes. Again, that's not even visible. It's visible to us if we look in their chart, but it's not going to ask for any manual input. That's done. The results are completed, and BrainCheck's interface with Athena is really great because it's all within the EHR. So the results are completed, and the results are actually done and put right into my results in the patient's chart. And it's digital format. So I'm not looking through a PDF looking for results. It's right there. So it's really optimized as a provider. When I now see them, I don't know any of that happened. All I see is, oh, great, there's a screening done, and I see what the result is, and it's right there. I can put it in my note, I can document it and move on. And that's what we envision across any EHR, any major EHR, because that's the point. We don't want to add anything to anyone's plates. That's where I'm really sensitive. I ask myself, am I willing to do this as a provider? You know, when I'm seeing patients back to back to back and I see 16, 20 patients in a day, I'm like, I'm not going to, you know, go digging through a P. I just don't have time. So we're setting up workflows with that sensitivity where we're not we want minimal involvement in terms of, you know, having to copy and paste or transcribe or any of that. So great question there. And then
Just to add on really quickly, as you touched on beautifully, Reza, we are fully integrated within Athena, but also Epic, and then the ECW is currently underway with the product team.
Great. And so to that point, yeah, since there's two parties here. So BrainCheck's got their integration, which we really you know, take advantage of, and then MedFlow kind of comes in and sits on top and uses that integration, but automates even further. There's a question: are the reimbursement data projected values or values that were seen by the clinic? So we have reimbursement data. So it's kind of a combination. We've been doing screening and BrainCheck assess and care planning for at least 3 years now. And so I have, you know, real data about what are we currently reimbursed. That initial data, there's some projection in there in terms of those are real numbers for screen and assess. And then, as you know, because this is all relatively recent, you know, the time sometimes for payers and whatnot to pay, depending on the payer, you know, there's some delays. So some of that graph was based on projection, but relatively confident projection given our few years now of working with payers, doing the testing, being reimbursed, you know, on a manual basis. And then Mary, I may have to I'm trying to, the first question is $25 per test for both screen and assess. Or I'm not sure if you know, or if we need to get back.
Sorry, I can't see the question, so you might have to read it to me.
Oh, okay. The question is $25 per test for both screen and assess?
So screen doesn't have a cost. Screen is entirely free since it's not a reimbursable product. And assess right now, I think our average per test, and you know, with recent changes in BrainCheck pricing, the pricing restructuring has been a big topic from the management team, but we're trying to sit at about $15 per test.
Gotcha.
It really depends on if the customer is set up through like a subscription plan or a per test plan, but that $15 average is really the goal across the company.
Right. And you'll see, depending on where you are, your population, your payer mix, you know, percentage of various payers that represent your population. We found in our area of the country and with the payer mix we see heavily Medicaid and Medicare, but we do accept, you know, all private insurances too. They tend to pay a little bit higher. But the reimbursement for the assess, the interpretation, which is the 96132, that tends to be good enough for us to cover our costs, you know, for BrainCheck and have some extra. So in our case, our average reimbursement is in the high 100s in our clinic. So, you know, 190, and in some cases, even some payers pay over 200 for that 96132. We also do, because we proctor, we bill 96138 for proctor by an assistant. And that's about, you know, anywhere from $30 to $40, $50. So again, there's a range. If you look at your fee schedules, you'll have your answer pretty quickly. You'll see what the reimbursement is, just to give you an idea of kind of the difference. And I will mention the care
Fantastic.
plan. Once you get to the care plan, that's a different code, 99483. That's a much heftier reimbursement. Total RVUs on that is actually a little over 8. And our reimbursements we see are anywhere from $400 to $600. So it's quite a significant reimbursement, knowing that definitely a lot goes into that. BrainCheck makes, in my experience, BrainCheck is the difference between it happening and not happening. I've been a part of 2 different Alzheimer's disease research centers nationally. So one of the 31 NI National Institute of Aging centers, meaning that the country's leaders in Alzheimer's care, and we were never able to get care planning off the ground, and that's with a major academic centers with a lot of resources. It's too complicated. There's quite a few assessments required. There's quite a few parts. With BrainCheck, it's so streamlined that it's made it relatively easy, which is so it's been amazing to see the difference. Any other questions or comments? Oh, nice. We got a question about some competition. We currently use Crayos at our clinic. What are some advantages of BrainCheck? Um, and I think my CEO is on the call, so I have to be really careful about how I I'm being a clinician, right, and a physician first. I'm just happy if anyone's doing any cognitive testing. That's my commercial answer, of course. And I think this question is maybe in some case, to some degree better taken offline in terms of like, we could probably go really into the details. I'm
Sure.
not, I know, Chris, I know I've seen them at conferences. I've tried the testing myself. It's been a year or more since I last did, so I don't know that I'm always, I don't want to speak without the most up-to-date details. So if you're able to send us your information or reach out, I'm happy to do some more homework and really understand the differences. I've heard good things though. I know many people that do use them. I don't, but I haven't used it recently enough to know exactly where they're at. Yeah, I'm not trying to dodge the question too much.
Yeah. The only thing I'll add there, I mean, I totally agree. I think that anybody that works in the DCA space is really just passionate about expanding access.
Hmm.
Um, but I think one of the key differentiators, at least when I last look at the competitor landscape, was our screen offering and having that like quick checkpoint available in a
Yes.
remote setting, 3 to 5 minutes. I know that they have a well-validated cognitive battery that is digitized, but I don't think that they have the multiple steps or that quick screen that's really intended to be a parallel to your MoCA, mini mental, slums, those type of tests or your screeners. They just have the full cognitive battery, and so I think that that's a strong differentiator for BrainCheck.
Very good point. I have not to date seen anyone that really looks at the whole spectrum, right? Because at the end of the day, you don't want to inadvertently move a bottleneck from one place to another. You got to release the
Yeah.
bottleneck across. So it's screening, assess, care planning, everything. Um, we've also, Chris is reminding me too, and I know this is true across much of our competition, is that again, we thought about BrainCheck. How can we reach anyone? It can be used on any device. So if you have a patient
Yep.
at home on a laptop that you don't really have control over, we've measured and validated across devices. And so we're able to provide you population-based results based on the device they're using. So not everyone has to use, exactly the same iPad or whatever it is. That's a big one.
Yeah, iPad, iPhone, web browser, pretty much any smart
Yeah.
device is compatible with our platform.
BrainCheck is also multilingual, and we also try to include as many of the screeners as possible. So I think we have over 22 of the various screeners. So it might be, I also want to, might as well ask them about ADHD or depression or anxiety or, activities of daily living or whatever it might be. So again, just so you don't have to figure that part out yourself. Um, there's one
Yeah,
other.
I think that's something that one of the tremendous benefits of BrainCheck that we didn't really touch on here are all of the digitized health questionnaires that again really just help streamline the documentation and provide additional context to that score that you're seeing from the patient, whether it be geriatric depression scale, ADHD, as you mentioned, anything like that. It all lives within the BrainCheck platform and paints that comprehensive picture of a patient.
And that's actually another comment was just submitted, which was right on that is, do we use other health data to assess? And so to Mary's point, all those screeners, so we're absolutely looking at, for the care plan, for example, it's required parts of it. We collect caregiver responses across a series of measures. We collect patient responses. So we're looking at, those activities of daily living, neuropsychiatric, symptoms, functional questionnaires, all of that. BrainCheck does incorporates all of that. We don't get into ourselves, although our diagnostic checklist for the providers, we guide providers to consider certain labs, neuroimaging, but we don't interpret or incorporate those directly ourselves, just because that's, it's harder to control, of course, and and as you know, dementia doesn't have like a final, an absolute requirement in terms of how it's diagnosed. Yep. And then David, in terms of published papers, I can, and I probably, because this is my first time using this kind of Zoom presenter view, I can try to track down your information. But on our website, there is a science section that's probably the easiest, and it has all of our listed publications are right there. If you have any trouble though, or can't see them for whatever reason, just let us know. But if you just go to braincheck.com, you'll see the science section.
Yep, exactly. They're all there. Should be up to date. We had a new one come out last week in digital health. So if that one's not on there, it's the only one that would be missing. But I think we do have contact information for all of the registrants
Oh,
today,
good.
and
Okay.
can send follow-up information inclusive of BrainCheck's publications.
Perfect.
All right.
Great.
Sorry, Riz, I know I can't see the questions. Are we through them all, or do we still have some more to
We
go
have,
through?
no, that was all of the questions. And then just one other
Okay.
comment, a reminder from Chris pointing out some of the differences is, again, our platform is sort of agnostic to device and situation, so that
Mhm.
because a lot of the other solutions do have certain requirements that do, just introduce some challenges, like they have specific stylus, that has to be used in an in-person setting, or you have to use the exact same computer. And so these, that does make a difference. Of course, in my population, that to me is a deal breaker, just because I'm reaching people in rural areas that I can't ask them
Absolutely.
to come in.
Yeah, really the vision has always been anytime, anywhere, and to be the most user-friendly and accessible platform.
Right. The last question I see as of right now is what kind of memory testing is available. And if I understand this correctly, I'll do my best to answer it, but please let me know if I'm off the mark. So BrainCheck is based on traditional neuropsychological testing that we've over time validated and digitized and revalidated. And so it's a lot of the tests would be familiar to you if you've been familiar with like neuropsychological test reports. Some of them are, have been around a long time. And then there's an element of time tracking and accuracy tracking that obviously we've introduced to make it adaptive for like digital format. So like on the computer or on the app, on the iPhone or whatever phone you're using. So we cover a bunch of domains. I guess that's probably the easiest way to answer it is we cover executive function, memory, attention, and so on. So that's, yeah, I'm doing my best to
I think the
answer.
only one you're missing there is processing speed.
Mm-hmm. And so
Yep.
we try to cover the domains. And our new validation study right now is going to release some new areas on language specifically. And so that'll be out soon. Mary's been very hard at work and doing a great job there. So we're really excited about that, actually. So that'll be great.
Yeah.
That's it's funny. I'm like, I think we're done, and then we get new questions.
No, it's great. The questions are the best part.
Do you track the time necessary to provide correct versus incorrect responses? Yeah. So the nice thing about being digital is we're tracking everything. Where are they clicking? Are they clicking in the right, some of it's visual, some of it's word memory, it depends on what the test is. But we're tracking time and really down to milliseconds. So when we're comparing you against your age-matched control, we're able to really have a pretty tight performance window. So we know, okay, if you're 20 years old, right, this is how fast an average 20-year-old can do this test. We can give you a good comparison. But yeah, absolutely. We're tracking. I mean, anything you can think of is being tracked, and we're using that to try to provide the most accurate, result possible.
Yeah.
So right now, that's all the questions.
Okay, great. Well, I think we can wrap up there then. Thank you so much, Reza. And thank you to all for attending today to learn more about remote cognitive testing and more about BrainCheck. So thank you.
Thank you, everyone.
Thank you.